So welcome. I guess we'll get started. So once again, we're back doing our homework. Hi,
Did you start it?
Yep, I did. So chapter 6 is what we're going to be covering. And I know you're all experts at it at this point. Right? Yes, you are. Yes, you are. Okay. So narcotics. And we watched this one. This was that old dogs clip with the Robin Williams in it. Such a funny clip. I love that clip. Okay. Moving on. There we go. So why is it important to know about pain control? We covered the NSAIDs last in chapter 5, but in chapter 6 talks about what if that doesn't help the person? We have to take and come to the next steps. So it's very important to be able to know how to read your patients so that you know if they're shoppers or if they truly are in pain, what's going to work best for them. Make sure you check out your health history, see if they're not allergic to anything. Doubtful that they're allergic to anything, usually it's the side effects. So like you take Norco or hydrocodone, which is Loratab, a lot of times you get itching. So that would be a side effect, not an allergy. You guys are good at that stuff, right? Huh? What's the other thing that everybody always says narcotics give them? I'm allergic to it because it makes me throw up. That would be a side effect, not an allergy. And also constipation. So constipation is not an allergy, it's a side effect, which could be a good thing on that, right? Okay, so here we go. So opioids, it comes from the poppy plant. We've all seen Wizard of Oz, right? There's a reason why they all fall asleep in the poppy fields, because it makes you sleepy. So it's the capsule of the poppy, and we'll see a picture of that in a second. So the narcotic word comes from Greek, so an opioid and opiates is derived from the poppy seed. And I gave you your PowerPoints back a couple weeks ago. So this one is about 10 minutes. It talks about the history of abuse and use of opioids. Kind of interesting. Okay. All right, so here's the structure. So if you look on the chapter 6, there's a few boxes here, and I'm sure you've looked at these, but it talks about the different types of opioids. So there's the pure form, and then you have mixed, and then you have the synthetic type. And then the table below in chapter 6.2 is the main ones that we hear of, so Demerol, all that good stuff, and then what they're mixed with. So oxycodone is Percodan, Percocet, all of the mixed types. So, and then what schedule they would be as well. Okay. So mechanism of action will be kind of moving along. There's the poppy seed pod. And we all heard of poppy seed muffins, right? Love those. Good stuff. That's where poppy seeds come from. But the actual, what they use for the drugs is they scrape the side of the poppy, and then it's the kind of like the sap in the pod of the plant, not so much the seeds. But if you eat enough seeds, it will show up on a drug test. So let's see. This is super quick one. There we go. Hopefully the volume is working. We'll see. It's muted. Ah, there it is. Mute. And look, it opened like 16 windows. Please do it. Okay, well, it's not wanting to. We'll be moving on. Okay, next one. This is a picture in your book. It talks about the receptors. So we got it's kind of like the cell membrane here, how it enters. So we have the agonist, antagonist, opioid, all those. and then how they get into the cell membrane. We got better, I wonder if I could get that to work. The video was much better. Let's see. Why not? We'll try it again. It's only like a minute long. Yeah. There we go.
Explore your brain on opiates.
Yay.
We need to understand a few things. An opiate is a chemical derived from opium and is the key ingredient in heroin. Those narcotics in your medicine cabinet, codeine, oxycodone, hydrocodone, they're opiate-like, but they are man-made and more commonly referred to as opioids. So how do these chemicals affect the brain? One big way is by exerting powerful pain relief.
Yeah, that's weird. It's like, okay.
Before we can explore your brain on opiates, we need to understand a few things. An opiate is a chemical derived from opium and is the key ingredient in heroin. Those narcotics in your medicine cabinet, codeine, oxycodone, hydrocodone, they're opiate-like, but they are man-made and more commonly referred to as opioids. So
we'll just get that big. Okay, there we are. I think we got it. And play. Come on. Right there.
How do these chemicals affect the brain?
Perfect.
One big way is by exerting powerful pain relief to the rest of the body. Chemicals flood the system and latch onto millions of opiate receptors peppered throughout the body. Think of opiates and the receptors like puzzle pieces. When they bind together, pain signals are dulled, or they go away altogether. If the brain already has opiate receptors, doesn't that mean it can naturally provide pain relief? That's right. Feel-good chemicals like endorphins are natural opiates that dull pain and also give you a rush. The problem with man-made opiates that mimic endorphins, take too many and they can overwhelm the system, give you too much of a rush. That can lead to dependence or abuse. Addiction becomes an even bigger problem because opiates also slow down breathing and heart rate. Mix them with other things that slow down your body, and everything could grind to a halt. In fact, every 19 minutes, someone dies of an accidental prescription drug overdose. Most of the time, it involves an opiate. It's now more common than dying in a car crash. If you want to avoid that fate, don't take more than you're prescribed. Don't use other people's prescriptions. Never mix opiates with alcohol. And maybe try other ways of alleviating your pain, like over-the-counter pain relievers and good old-fashioned exercise.
Because we all know exercise makes your toothache go away, right? Just tell your patient, go to the gym. I don't think that'll work, but there we go. Here we are. All right. Okay. Here we go. So the opioid pharmacokinetics, you got the ADME, so absorption, distribution, metabolism, right? There we go. Thinking metabolism and excretion. So absorption usually is by mouth. However, morphine can be given IV. There's other ways, but usually it's orally. Absorption can come in the lungs for anesthetic purposes and from the nasal oral mucosa. So the Gene Brown wisdom tooth studies, have you guys referred anybody to those? They were studying a pain med that you would spritz up people's noses. I don't know whatever happened to it, but that was one of the studies that they were using. My nephew did that one.
How did he, was it effective?
It was for him.
Yeah.
Yeah, and he didn't share the $300 with me either.
Next time.
Next time. So let's see. So the distribution is where it's, it affects the CNS, so the central nervous system, okay, not the peripheral. Remember the notroreceptors where, the pressure, pain, burning. So it's the sands and the pans, okay? We love that chapter 4, right? It's like rip it out of our book and ignore it. And it binds to the receptors in the brain. That's how it works. So the pain is still there, but it's turned off in the brain, not blocking the prostaglandins. And usually it's excreted through urine, so guess what? Drug tests usually are involved peeing in a cup. Alright, so on the next one, so opioids. So we got major ones like the morphine on down to codone to hydrocodone with codeine, which is Tylenol 3. So after you give somebody enough to take care of their pain, you can give them more, but it doesn't actually make them have less pain. I mean, there's a threshold where you meet where you just can't keep giving them. It's not going to make their pain less. You just slow down their heart and their lungs, and yeah, you die. So yeah, not good. So like just is accidental overdoses. Sometimes with hospice, they will help keep people comfortable with morphine, especially if they're in pain with pancreatic cancer or something like that, and they would control it with the morphine. They just keep upping it a little bit at a time. All right, so we got anesthesia, obviously pain, sedation, and euphoria. So if you've ever met anybody who has a problem with this addiction and you're just talking to them, they're really mellow. Nothing really bothers them until they get too much or they mix it with alcohol, and then they have like all this energy and they talk real fast. Cough suppression. So this is the Tylenol 3. So when you have a baby coughing all night or you're coughing all night, they give you Tylenol 3 because it makes the cough receptor inside of your brain, it miles that down so you don't cough as much. It's a great thing if you really are coughing a ton. Okay, so antitussive, that means anti-cough. And the GI, so it increases the smooth muscle tones, so you have less contractions and motility. So if somebody's having extreme diarrhea, they give you like an opioid, but if maybe you're not and you're taking it for your knee pain, you still have that side effect. So always talk to your patients about that. Kind of embarrassing. You're like, okay, have you taken this before? What has happened? Maybe, get some salads or something. Okay, so this is a map of the highest uses of opiates. Did I show it to you last time? Yeah, it's kind of shocking. We're kind of a bright red color. Here's the next one. So this, I think I explained this one to you. So out of every 100 people, how many of those 100 people have an opioid prescription at home or currently taking one? And if you see, Utah's right here. So 86 people out of every 100 people have some kind of narcotic at home or they are taking it currently. That is a lot of people. That's so shocking to me a little. So let's see, so out of 10 people, like 8 people are taking it, I guess, if you make it a smaller number. Yay, Utah. Okay, so like other drugs with adverse reactions, they don't directly damage the hepatic, renal, or the hematologic tissue, but they can have an extension into those areas. Okay, and then on number 4, the table, it has kind of adverse reactions right there. Kind of an easy, quick glance to look at. All right, next one. So all those adverse reactions, I've just kind of broken them into their own slides. So you have respiratory depression. So it's not a problem if you normal usage in normal healthy patients, but it can cause death and overdose. So that was the number one. What was it? Higher than car accidents. That's 1 out of every 19 seconds. Somebody dies. The brainstem is no longer as sensitive to carbon dioxide, so that you don't want to breathe. So it kind of just slows everything down. And then you're sedated, so you just like kind of fall asleep. Okay, so patients with maybe liver problems, kidney problems, already sick, and they're not able to, their body isn't functioning like a normal person, you would want to use these with caution. Okay, so nausea and emesis, so that's throwing up. So a normal dose can make people nauseous, but because it stimulates the CTZ, chemoreceptor trigger zone in the medulla, that's in your brain. And the side effect, it can reduce, let's see, the patient doesn't, so you can use it in, there's a form of it that they use it in this transcope patches that you take on cruises, you put it behind your ear. It helps you so you don't get motion sickness. It's a really low dose patch. Has anybody used that? Yeah, me, Shane back there has. Works pretty good. Repeated doses can actually prevent vomiting by depressing the vomiting center. So it's like at first it makes you sick, and then you give you more, and then it suppresses it. Constipation, yay, we talked about that. It does not, the duration, it outlasts the anesthetic effect. So you take whatever for a toothache, a root canal you had, so you take Lortab. And then Lortab lasts 4 to 6 hours, but the effect on the intestines lasts longer than the 4 to 6 hours. So just, it's kind of an interesting thing how it outlasts. So, okay, this is the only eyes that I could find for pictures that showed a dilated versus a non-dilated. So meiosis is the constriction of pinpoint pupils, and I've seen this on people. Anybody seen this on people? Yeah, I think they kind of pre-medicate themselves to come to the dental office, all right? It is something that you do not have a tolerance to. So you have somebody who is on opioids, addicted to them, have taken them for years, and they get tolerance to the opioids, but they always have the eye side effect. So that doesn't change. Urinary retention, so the smooth muscle tone in the bladder, and then it can also produce stimulation, which makes you anxious, nervous, restless. People won't sit down in their dental chair. Okay. So overdose reactions the vagus nerve is stimulated, which is what? What cardiovascular? The vagus nerve goes. Which number is it? I forget. 10. Thank you. I'd have to draw my picture. Postural hypertension, bradycardia, and even syncope. What's that? Fainting. Yeah. I always think of syncopation, and I don't have syncopation at all. Terrible. Pregnant and nursing, it will prolong labor and depress the fetal respiration. So when the baby is born, it's called the floppy baby syndrome. So they are just like super relaxed, which is a problem if they're not breathing. Yeah. There we go. We'll just go on. Opioid addiction. It happens a lot in families. Probably you know one or more people who have had this problem. Sometimes it's because they had back surgery or something and they needed them at first, and then they get addicted because of the pain, and it's just this terrible cycle. A lot of articles recently I've seen on pro athletes who had so many surgeries. I have football players having surgeries, and then they retire and they're in pain for a long time, and then they just get addicted to it. It's kind of interesting that even these people that you think are heroes can still be trapped in that terrible cycle. So, withdrawal, yawning. I think that's weird. It's not weird to be a withdrawal of yawning. Your eyes cry, you sweat. Rhinorrhea, what is that one? There you go. Goose flesh, so it's like you have the cold turkey. That's where that comes from. Irritability, yes, they're a little irritable. I get irritable when I don't get caffeine, and it's 10 times worse. Nausea, vomiting, tachycardia, tremors, and chills. So, ways to identify the addict that will come and see you, and it happens a lot more than you would think. It's amazing how many shoppers you get, but also patients of record that you've known for years. So they request a certain drug by name. They're the best walking PDRs ever, right? Drug users. They know what to mix with what and how long everything works. So they'll say something like, I need that one. Oh, I don't need, I'm allergic to Tylenol 3. No, I'm allergic to that, but I usually like that Perca, they'll do something like that, and you're like, you know what you're talking. Percodan, Percocet, you know. I can only have that one. I'm not allergic to that one. Okay, you are good. Yeah, claims many allergies. I can't take Advil, I'm allergic to it. I have to take Percocet, which is kind of funny because ibuprofen happens to be in that. All right, cancels dental appointments, yes. They experience pain several days after treatment. They just don't seem to be getting better. Another one I like is they fell and got flushed down the toilet. Can I get another prescription? My purse was stolen. My car was broken into and the prescription was inside. Those are all ones you hear a lot of. Goes from office to office, saying they don't understand what the treatment is. And claims low pain threshold. We learned about that in number 5. Have you guys been seeing that? You guys are in clinic now. Have you been like thinking about pain threshold and how everybody experiences differently? It's amazing, isn't
like
it?
Nitrous.
Yeah, nitrous is great, but you know, you're like doing something so easy and the person before you could probe, no big deal, they didn't even move or complain, and then the next person is like moving all over the place and they think you're torturing them, and you're like, what's the difference? You're not changing the way you probe or push, or I hope not, unless you don't like that person. I'm gonna push really hard on you. Okay, needs refills before their time is due. Oh, I had to double up this weekend because I'm in so much pain. All right, so healthy brain and opiate dependence in 7 years. I think I can tell the difference. I'm not a neurosurgeon or anything, but I think you can tell the difference too. All right. Okay, so here is a lovely picture. Kind of helps you understand all the things that people are going through. So you got the cold turkey over here. You got the guy throwing up. Muscle cramps, abdominal pain. I'm not sure what the baby on the ceiling is. There, maybe. That's probably what it is. I'm like, okay, that's just creepy. That's a exorcism. The baby you see on the top, climbing yeah, that makes sense. Yeah. Okay. So adverse reactions. So there's a couple more pictures of poppies. I think they're kind of pretty. I don't know. So you can get skin rashes, urticaria, true allergy is present. The true allergy is common. It's a lot like anaphylactic shock. Okay, and you all know how to treat that, right? Good. So addiction can be anybody can have an addiction to opioids. It's not the scary person that's the homeless person down the street. I mean, it could be, but it could also be your neighbor or your aunt or anyone. Okay, this is the codeine allergy tree, and it's a little difficult to understand, but one thing that you need to remember about codeine, Tylenol 3, is that is what? The most commonly prescribed narcotic in dental, yeah. Okay, so this is a list of what is the most abused out of all the medications. So obviously, here we go, we got Lortab, or Norco is what we call it now, Vicodin, on down, here's Tylenol 3, Percocet, Percodan, all the way down to Ultrims. Anybody ever know what an Ultrim is? No? I had a brother-in-law who, you can order him off the internet. And he was, I don't know, ordering $800 something a month worth of it. And he had to wean himself off. Demerol, all those good things. Oxycontin, that's the big one that everybody breaks into pharmacies for. Morphine. Anybody have morphine before? I have.
Yes, I have a bad reaction to that.
Do ya? I didn't like it at all. I mean, it took care of the pain in my foot. I was walking in a flip flop and my feet were wet and I slipped and it cut between my toes.
Ooh.
That was fun. Yeah, enjoyed that day. So they gave me that. But I didn't really like it very much. It made me kind of crazy in the head more than normal. And I couldn't like relax. I mean, the pain was okay gone. I was like, but then they came in and gave me shots all around my toes, so that helped with that. That was awful. Oxycodone. Let's see. So is with aspirin, okay, and acetaminophen is with Percocet. So Percodan, aspirin. That's what they mix it with. Okay, severe pain. Yeah. Oh, Tylenol 3 there. I'm just kind of, okay, so these are the, what you would give patients if you were gonna prescribe. So hydrocodone, Norco. I don't know why they changed the name. Does anybody know why they changed the name? Somebody said, oh, so that they can trick all the drug dealers. I'm like, I'm sure they're on to us. Patent or something? Oh, that would make sense to why they have to change the
But I
name.
don't know.
Yeah. So it's 5 milligrams hydrocodone with 500 milligrams of acetaminophen. And then you have 10 milligrams of hydrocodone is 750. So you're like, oh, interesting. So it's a mixture pill. And then codeine is look, most commonly used in dentistry. It's on the slide, so it must be true. Okay. Methadone, they use this to help people get off of, or if they're addicted. However, it can also become an addictive substance. So they use this for heroin, and then people start abusing the methadone. I saw that a lot when I was at the homeless shelter. Oh, I need my methadone medication. You know, and they're like, oh, really? So this is from the fentanyl family. It's short acting. It's an agonist against opioid analgesics. So it binds to the receptors in your brain faster than the Lortabs or the hydrocodone, so they don't get that same feeling if they take an opioid because the receptors are blocked. What time is it, Shaner?
Got 3 minutes.
All right. There's a big push right now to have these safety kits in high schools, hospitals, people in their cars, police car trunks. Because if somebody's going and having an overdose on an opioid, you can give them this particular, the Narcan. Anybody heard of Narcan? You've heard that on like the medical shows on TV. And so you give it to the patient and it helps to reverse the respiratory depression. Has anybody seen this in the news? Yeah. So a lot of parents who have had teenagers and young adults who have overdosed on opioids, there's a big movement behind that.
And police officers are carrying this now.
Are they? Okay, that's good. I wonder what's in their trunk. They must have it shoved full. So let's see, they have the shocky pads. What are those? Yeah, and then they have all like a drug department in the back. Yeah. So on this little picture, kind of shows that it blocks the receptors. So even though it's in the system, it blocks the receptors, so the narcotics can't keep going. Tramadol, that's the Ultram. Dental uses for opioids. So, some offices our policies are we do not prescribe opioids. None. It's Advil or nothing. A lot of offices are going to that. Anybody been to an office, dental office like that? The patients just say, oh, what am I going to do over the weekend? It hurts. You're like, well, you get here's an 800 milligram ibuprofen. We don't do narcotics. And they'll usually have a sign in their waiting room, and they'll have the paperwork for new patients. When they fill out the paperwork with their history, they'll have something in there saying we do not prescribe narcotics, which I have seen people get up and walk out. Interesting. That's always interesting, like, what were you here for? Okay, let's see. So you begin by something lower and then work your way up, obviously. Oxycontin, I've never seen a dentist do that one. Anyone? No, maybe an oral surgeon. The highest I've seen is like Percocet, Percodan, and Lortabs. Okay. Dental uses, how are we doing on time, Shane? Are we done? Okay. So opioid prescriptions should be given in small amounts. And without refills, of course. So do you give your patient 30 tablets? No, you give them like 10 or 15, and that makes them mad. Am I good? Okay. I know, they all lived happily ever after. Yay! Good job, everybody, for snooze.